Bickerstaff brain encephalitis and neuronal linkage. Bickerstaff brain encephalitis is a rare immune-mediated neurological disorder in which antibodies, especially anti-GQ1B, target neuronal gangliosides involved in brainstem and cranial nerve signaling. The result is dangerous breakdown in neuronal linkage between the midbrain pons, cerebellum, cranial nerves, and reticular activating system. Hi, my name is Dr. Wes, and today we're going to discuss Bickerstaff brain encephalitis. Bickerstaff brain encephalitis is a rare post-infection immune-mediated inflammatory disorder primarily affecting brainstem. The major role is played by anti-GQB1 antibody spectrum. Epidemiology less than 1 per million per year. That is the epidemiology of this disease. Clinical triad: extraocular muscle palsy, diplopia, cerebral ataxia, altered consciousness is the major triad of this disease. Onset of disease: this disease preceded by infection, the upper RTI and GI infection that leads to the Bickerstaff brainstem encephalitis. Additional features: facial palsy, limb weakness, hyperreflexia, reflexia, pupillary abnormalities. Disease spectrum: it's have a mimicry. This disease have a mimicry with Miller-Fisher syndrome and GBS, Guillain-Barré syndrome. This disease is first described by Edwin Bickerstaff. That is the reason that is the name designated to this disease. Etiology: BB is triggered by preceding infection causing molecular mimicry. Anti-GQB1 is the major player in this disease. Mostly this disease is led by the Campylobacter jejuni, Haemophilus influenza, Epstein-Barr virus, and SARS-2 virus. Molecular mimicry, that is the same. GQ1B is the major gene, and anti-GQ1B is the major player in this disease. The pathogenic antibody, GQB1 is complex ganglioside containing sialic acid linkage, highly expressed on cranial nerves, especially cranial nerves 3, 4, and 6. Anti-GQB IgG detected by 60% in 60% BB patients and plays a major role. Antibody mediates complement activation and disturb the neuronal muscular transmission. Immune restrictor HLA association, human leukocyte and leukotropic factors are involved in this, and immunocompromised state, HIV-like patients have more probably chances of getting this disease. That is the disease mechanism. Preceding infection, the major players are the Clostridium jejuni, Epstein-Barr virus, cytomegalovirus, and influenza. Mimicry is the GQ1B. Polyclonal IgG response, cross-reactive autoimmunity, and complement activation. That is the most important part of this disease. C1q, C3 MAC cascade is involved in this disease. Brainstem inflammation, in which T cell infiltration, cytokine release, and demyelination occur. That is the clinical symptoms: ophthalmoplegia, ataxia, and altered consciousness. These are the roles. The most important part, this disease and the factors involved in the disease cause is the blood-brain barrier disruption. That is the neuronal mechanism. BB is progress resto gradually or resto caudally in the brain system. Ophthalmologic midbrain ataxia and errors causing activation of lower cranial nerves and respiratory failure in the patient. That is the neuronal mechanism. Nerve terminal destruction. Anatomy of consciousness disruption and cellular and central inflammation in the brain. Demyelination is the major part of this disease as compared to axonal injury. Cross-reactivity across the anti-GQP1 spectrum. Cross-reactive antibodies targeting different ganglioside combination determine whether the clinical phenotype resembles the MFS, BBE or GBS, which type of disease. This is the criteria of the clinical diagnostic. Classical triad, ophthalmoplegia, cerebral ataxia, impaired consciousness, and the resemblance with the other diseases, the most important part. We have to exclude the stroke, tumor, Mimicry, encephalopathy, and brainstem vesiculatus. That is the antibody testing for GQ1B and anti-GQ1B. MRI and brain stem imaging or neuroimaging should be included while diagnosis is in process. CFNS analysis is the common diagnostic part. Electrodiagnostics, NCS, visual evoked potential VEP and where EMG. This is the differential diagnosis. The most common observation during this disease by the physician is the similarity between the BBE and Miller-Fisher syndrome and their symptoms. So that should be analyzed and show proper diagnosis should be there for the patient. That is the treatment. Intravenous immunoglobulin, plasma exchange, corticosteroids, ICU, supportive care, mechanical ventilation. That is the symptomatic rehabilitation management. Eye care, exercise, speech language therapy, neuropsychological evaluation, and the provision provided by the hospitals and the family support.